Hi, I'm Dr. Raj Aquila. I'm UK Ambassador and Global Key Opinion Leader in Facial Medical Aesthetics. Welcome to my series of online training webinars. First position is going to be at this number 1. Now, the objective here is that we give this lifting so that we already start to see an improvement within the mid-cheek groove, but we start to see some changes here at the lateral canthus and softening and blunting of the nasolabial fold as well. If we're really lucky, we start to see some positive changes at the oral commissure too. So let's begin and see what happens. So first injection here, you see I'm holding the zygomatic arch with thumb and forefinger, and the point of this is I'm identifying the zygomatic arch, and then I'm going to pull the skin back already. When I pull the skin back like this, I'm repositioning the skin, and then I'm allowing me to almost fix the skin into a higher position. So when I release the finger now, do you see how the skin is tethered behind the needle? So we were doing this actually in Monaco, and Maurizio was calling this hammer and nail technique, which I don't think the patients particularly appreciated, but it's certainly a good analogy because literally you're like taking a piece of paper and sticking it into a drawing board with a drawing pin into a position that you want to. So this is going to be 0.2 cc, and the reason for this is because I do actually want to generate a little bit of lateral projection as well as generating lifting. Now, did you see when I took the needle out, the skin didn't fall forward as much because it was already stuck into a better position. So then I take that little bump and I'm going to mold that back now. And in fact, look at the interaction of this point with the lateral canthus. This is that mechanism I'm talking about with indirect changes in the lateral lid cheek junction. So that's our number 1, and then we're going to come forward and we're going to treat at number 2. Just change the needle, thank you. So this is now with, perfect, thank you. Now you'll notice that I'm changing the needle. Why did I do that? Because I'm touched the bone, and intrinsically I'm going to blunt the needle. It means that as I drag the needle tip through the skin, I'm going to create a little bit more tethering, which will be more uncomfortable for her, and much more chance of a bruise. So just change it. They're cheap as chips, these things. Okay, so next point is the intersection of the outer eyebrow hairs with that upper alar tragus line, and I just fix a little cross, and I want to project at that point. We know that injection at this point will make any female patient look more beautiful. It's a fact. It's been calculated. So we're going to identify inferior border of the zygomatic arch again. We're injecting about 1 centimeter above this point, down to the bone, and then a nice big aspiration. You can see the bubble in the syringe here, and then we can start to inject. And as I inject, I'll start to see some local changes. So I'll see that the tissue is elevating. I'm going to see also that the lateral lid cheek is starting to become a little bit softer. And again at this point, because she's slightly volume deficient, we're going to go to about 0.2 cc. So she's had 0.4 so far. Take my little bump, because this is not a result. Remember, it's all about the molding and the interaction of products and tissue. Take the little bump and then mold it laterally. Then take the little bump and mold it upwards like this. And I'll do that until I can feel that basically the product is squished away. I don't want to feel like there's any excess whatsoever. And when I'm happy with that, then the injection point is complete. So we never move away until that's done. Now, after these points 1 and 2, I do like to evaluate what it does to the cheek, but also to the lateral eyelid. Look at this. That's really interesting. So keep this, Chris, keep this image, please. Can you see on the untreated side how she has a deformity in the lateral lid cheek junction? Also, how she has the skin excess here, and she has this little malar mound with the exacerbation of the mid-cheek groove on this side. So I didn't inject lower eyelid, but all of a sudden she starts to get better there. It means I need to take less product. I need to inject with less points within the lateral lid cheek junction, and that's less risk for the patient, less chance of a black eye. Okay, so let's face it, these things can happen in that area. Also, what I would say is that there is a subjective appearance, if you look at the two eyes together, that the left eye is a little bit more attractive. And the reason for this is because she has had a slight lateral canthal tilt upwards, and that's because of the superior elevation of the tissue below, giving this kind of effect. So it's doing this kind of approach from the lateral part of the cheek. So already I'm starting to get very reassured that she's responding indirectly, so we can continue to go through the protocol. Let's just evaluate the mid-cheek groove. Turn this way, thank you. And you can see the festoon on this side there. You can just start to see that she has festoon and then a hollow. And then on this side now, she gets really nicely corrected. It's not gone completely, but it will go now with the next injection. Okay. Next point now. So a little wider, Chris, thanks. Stop. Perfect. Now what I'm going to do is I'm just going to touch the tissue and I'm going to rotate the SOOF and just see at which point I can improve the tear trough. Here we go now. So we've got a very nice correction when I just blot like this. So we're going to go now with the VoLift and we're going to inject the SOOF, so not superficially, not deeply. Let's just mark up the point so I know exactly what I'm doing. There it is. And you know, it doesn't matter how many times I'm going to do this, I'm still going to feel nervous about injecting it because 1, it can be painful, 2, you can have a bruise, and 3, it's an area at which we need to be precisely depth controlled. So I really need to be dialed in to be able to do this properly. So a nice controlled approach, and I'm not going to inject too shallowly. I change the needle axis and come like a bit steeper because I want to get to the target. So here is the skin, superficial malar fat, pop through now, and then now I'm in the SOOF. Take a nice big aspiration for safety. Make the injection. Remember, it's 0.05 to 0.1 maximum here. And there she has a bump now. Take the bump and make this bump become your friend. It's going to run now in front of my index finger, just like this. Look what happened to the lid-cheek junction there. You see how lid and cheek are becoming much more harmonious. Lower eyelid is starting to rise, agreed. She has more of a scleral show on the right-hand side. Let's do another little mold like this. And then we start to see this magic VoLift starting to integrate, becoming like a sheet. It wants to kiss the eyelid, it wants to kiss the cheek. It wants to spread across this area and make the whole area much more harmonious. So can you see now the slight tiredness on the patient's right-hand side, but also with this slight scleral show that she's having here in the lateral part? And when I test the stress of the tissue, so if I have a look at the skin integrity here, look at the recovery rate of the skin. I'll do it one more time. Look at how the skin, it sluggishly goes back to position. And then when I do it here, you see how it snaps back faster. And this is what I'm talking about with surface tension. It's a surface tension phenomenon. It's not a volumetric phenomenon. You're improving surface tension within the skin. Okay, I'll stay with this, thank you. Now we're going to go to the alar base. So we will now, that's it, perfect, thanks Chris. So the injection point here, remember what I told you, is going to be on the piriform in the first instance, and then I'll go a little bit more superficial here. So we're going to go steep first. It's nice and quick because no patient likes this at all. Take the big bubble. Now watch this. See the bubble is there now. I'm going to keep the bubble in for at least a second because sometimes you can have late flashbacks, and always be aware about that. I make my bolus, and the maximum volume here should always be below 0.3 cc, and that's because of compression of a very anatomically sensitive region. Can you see the left nostril is rising? Can you see that the left upper lip is starting to rise also? Take the little bolus and watch what I do with the molding there, in behind the levator labii superioris muscle. You can see the mechanism already, what I'm doing in terms of the lip and the nose. Okay, so what happens here now is that the upper 1/3 of the nasolabial fold gets completely corrected and effaced. The left nostril becomes higher, and she has a little bit more drag and pull on the left upper lip like this. Not that we're treating the upper lip, but we should also see, because of surface tension improvements, some degree of improvement within perioral lines in the left part of the upper lip. So what I want you to do for me now is just kiss very gently. Okay. Kiss, 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 kiss. Right. Can you see how she deforms a deep perioral line on this side, but on this left side she can't make the skin come together properly? Can you see how the lip is rotating this way because it wants to be pulled up in the left-hand direction? So this is yet another mechanism. We're helping each injection point by doing an effective one in the preceding point. So we change. Thank you. So we're going to stick with the Volift, and I'm going to go now. This is back to day one of filler school, right? So we're just going to do superficial, so the upper slice of bread of the sandwich, just over the top like this, and we just pop it out. So that's the upper third of the nasolabial fold is now fully corrected. Now, in patients like this, do we start to continue to chase that line directly with filler? It's really difficult to do. And when she smiles, the filler will pop out like a little sausage, and it'll become obvious she had treatment. Isn't it more effective, therefore, to be doing this to her to make it softer from an indirect approach? And that's really the objective. So this corrects this. This corrects the pre-jowl. And the subzygomatic space will correct this area if you want to facilitate more of this kind of effect back to the subzygomatic region. Okay, now we're going to go with oral commissure. So we're going to rotate the mouth slightly and just give her a slight lift. This is an intradermal or just barely subcutaneous injection. She has beautiful lips, so we don't want to do too much in the way of volume. Can you see the lip is rising now? And there what we've done is we have one lip going down and the other one is going up. Now, Chris, if we just start to show the full face from here to here. Stop. Good. Thank you. You know, we were talking about the emotional component of aging. On this side of the face, she is slightly unhappy. She has a sad eye and a slightly sad mouth. When you do this to her now, you see the openness and that degree of happiness and restedness that she has in her face, because she has two positive vectors. One is here and the other one is here. The two are marrying one another. Wait till we do the chin and jawline as well, and all of them come together as one. Now, and look, I didn't do her lip, but doesn't it look like she had a lip augmentation on this side? On this side is just the normal pre-treatment view. Yeah? I didn't touch the lip tissue yet. I'm just doing the framework. So now we're going to just continue that injection, and this is again just really simple. Everybody can do this. You just go anterior to the ligament. This is now going a little deeper, so we're going intermediate depth. Now we go a little bit deeper still, intermediate depth. And look, I'm not aspirating when I'm moving the needle. What's the point? Because if you're going to be in a vessel, you're only going to go through it. Now I go a little bit deeper, but I don't quite touch the bone here. Now I'm going to aspirate because the bolus will be a little bit greater. And then finally, we're going to change the product now, because remember I talked to you about going with the voluma at areas of peripheral lifting and stability, so architectural injections. So we go with the voluma now instead. Thank you. Perfect. Good. And to decide how exactly where do I put the voluma here, I'm going to stress the tissue. So she deforms at 2 points here. This is the insertion of the pre-jowl sulcus. This is the lateral border of the mentalis muscle. So what I need to do is inject anterior to the mandibular retaining ligament and its insertion, just here. So this will be the spot, and I'm going to go anterior to this. So I'm just demarcating the inferior border of mandible through the DAO onto the bone. There's the bubble, because remember you've got marginal mandibular artery here. 0.1, 0.2, maybe 0.3. It depends on the amount of concavity. This is going to be 0.2. And there it is. So I skew it on the way in, but aspiration means that you're not actually in it, and that's the key. So it's about knowing exactly where you are, what the potential pitfalls are, and then knowing what the implications of that are. So in this area now, you're just going to make little bit of pressure, but then mold at the same time as well. So here at Pre-Gel Sulcus, I want it to conform to the jawline like this. So I want it to be nice and smooth and flat. And actually, sorry, forgive me if I was wrong. I think it was actually Brisbane last year, yeah, when we injected here and we had the aspiration, positive aspirate. So that was like number 6, I think, that I'd got back then. And it's a good learning message, really. Okay, so she'll have a slight bruise here, but I should have fixed that to the Pre-Gel Sulcus here. So just relax completely, thank you. How did it feel? Was it painful? Yeah, okay, fine, she's fine. Now what I'm looking for is continuum of jawline, right? So I want a continuum from chin through to jaw, and before she had this concavity. So if I turn you now this way, thank you. And then if you just show me a kiss, please. Right, can you see that how she deforms on this side, and how on this side the tissue is completely stable? It's resisting pleating. And that's the mechanism again for fixing the transition between the chin and the jaw. Now relax. I'm just going to have a look at the profile here. Right, can you all see that she has jowl formation in this region? Chin is a hill. She has pre-jowl sulcus, which is a valley, and then she has another hill, which is the jowl. And so this is a slight disruption to the continuum of the jaw. So actually this is the desired effect. Now if I turn her to this side, and you can see that she's achieved a straight jawline. And that was actually even without injecting angle of mandible yet, only with pre-jowl sulcus. So now we're going to move to the angle of the mandible, given that we're in this region. And we're going to fix this point. So let's stay with the voluma, thank you, perfect. Yeah, thanks, perfect. Now, this is the angle of mandible here. I'm pinching it hard. And actually, when I did this, I just did this here. And with this finger, I actually pinched the external carotid artery. I felt it going through my finger just like a bit of linguine. It sort of just slipped through my fingers. And it shows how close you are in that area. So pinch the angle of the mandible. The injection point is going to be 1 centimeter superior medial. Remember, it's a subcutaneous injection. See, I love that jawline already. It's so steep and vertical, and now it's conforming to good parallel sequence between cheek and chin and jaw. So lift the skin, make the injection, flatten off. I'm in the subcutaneous level. Nice big aspiration. Release with the non-dominant fingers. And then now I can make a really safe injection. And remember, there's so many issues here. You have to be in the safe plane. So we're at 0.2 cc. I'm now going to take the little product and I'm going to stick that onto the ramus of the mandible. And you can see what I'm doing. Look below my thumb. You can start to see the true angle of the mandible becoming revealed. And what I'm going to do is here, I'm going to conform her now more towards the aesthetic ideal, say 94 degrees. But I'm also going to reposition the skin of the angle of the mandible into a better position, which is going to fix the jawline. It's going to straighten it out. Just do a nice little mold and a massage till it all goes. So take a look at this angle now. It's closer to 94, isn't it, here? And whereas when we look at the other side, thank you, just swap you. Great, thank you very much. See on this side, she's blunter because the temporobuccal fat has fallen down here and it's hanging in this area. So you don't get this nice vertical angulation point, and also look, she's hanging here and she's depressed here, and then the chin is depressed. So when we look at this side now, see she really tidies up this angulation point here.